such a repetitional page. Good afternoon, everyone. First of all, I'm really proud to give a presentation here in such a repetitional page like Divas and Laser. My name is Ayman Al-Amin. I'm a dentist from Egypt. I was graduated in 2004 from Cairo University. My first specialty is the restorative dentistry. I got my master's degree in restorative dentistry in 2012 from Cairo University. And my passion about laser started in 2013 when I bought my first soft tissue laser. In such time we didn't have a lot of education channels in order to learn dental lasers. So I have admitted to the fellowship of Al-Amin University. It was arranged here in Egypt in MIU, and I have finished it in 2014. And since then my passion about laser has increased a lot. I've got myself another soft tissue laser. I have an urban laser, so I'm working on soft tissue lasers since 2013 and on urban lasers since 2015. I've given a lot of courses, in private courses, educational courses, scientific days, workshops and conferences, lectures in conferences in Egypt and in Arabian countries, in foreign countries. The laser for me is a really a passion, because I really believe that laser in our field is a real problem solver. It can shift the treatment plan into an unexpected results if you just know how to use it. It's really easy tool, but it has endless uses, but you have to know how to use it. It's really useful. So nowadays the main concern of patients when they come to the dental clinic, aside of the pain relief, is the aesthetics. So when our patient is just demanding for aesthetics, in our field we just don't reach only aesthetics. Our main goal is reaching the balance between function, anatomy, aesthetics, hygiene, and duration and durability of these restorations. So to reach these, we have to use a lot of techniques and teamwork and a lot of specialities. We can use different specialities in just treating one patient. So in using innovations and new devices and new techniques in order to collaborate all these together in order to reaching the optimum treatment plan for this patient. And the main goal of these devices and technique is to decrease the time of treatment plan, decrease the number of visits for the patient, and increasing the quality and durability of our restorations. So in our dental field, the technology is really updated daily, and you have to be updated with these devices and these techniques. And I believe that if you are a dentist and you don't have an updated devices or updated knowledge about these devices, you cannot give really good treatment plans for your patients. So when the lasers came up in dental field, I consider it a revolution, a game changer in our field. The lasers have incorporated in another medical fields like dermatology and ophthalmology since a lot of years ago, but in dental field it has been recently distributed more and more in clinics, and the demanding for knowing the know-how of lasers have been the main concern right now for about a lot of dentists in all around the globe. So the laser dentistry, I believe that the laser is not just a device. It's a tool. It has a lot of applications. We can use it really every day. It's my right hand in shifting the treatment plan and in getting out more quality for the patient and decreasing pain. So aside of the laser dentistry applications, my lectures now I'm saying laser assisted dentistry. That's because I believe the laser is used in really every specialty in our dental field. I've got a series of laser lectures about lasers in endo, lasers in perio, lasers in surgery, lasers in pedo, lasers in restorative. So I believe that the laser is a tool, not a device. The device, it's something gets used for only one thing, but a tool, you can use a tool for giving out an endless uses and endless applications, like the maxillofacial surgeon. He just has a tray of these tools. He can do millions of operations. Okay, that's a tool. So my belief for the laser, that it's a tool. It's really helpful tool in fixing a lot of problems, and on the other hand, you have to know how to use it in order not to harm the patient or harm yourself. And then sometimes the laser is just can be used. So you have to know when to use it and when not to use it. In some applications and in some treatment plans, the laser cannot do the job, so you have to shift to another tool. But if you just understand how to use it and how does it react with the tissues, so you're gonna know when to use it and how to use it. The lasers has a lot of types, but in our dental field we use almost up to now these 5 types: the diodes, the Nd:YAG lasers, the erbium lasers with its 2 types, the erbium YAG and the erbium chromium lasers, and the carbon dioxide lasers. If you can just classify it into soft lasers and hard lasers, which is the better be called all tissue lasers, you have to know how this laser work. So you have to know the laser tissue interaction, which type of laser works with what type of tissue in your body when you use it. So when you point your laser into the tissue, you have to know where it goes, where it absorbs, which is the main reaction we need in laser is to be absorbed in our tissue. So according to the type of laser, which is limited to its wavelength, each wavelength of each type of laser is specific for it, and it does not change. It has ranges and numbers, and each number which will have a specific type of absorption channel in your tissues. That's we call a chromophore. The chromophore is the type of tissue that absorbs this specific type of wavelength of laser. So when you know the chromophore of each type of laser, you know how it's absorbed and how much it's absorbed. So as long as the number or the amount of chromophore increase, so this type of laser is going to be absorbed more, and vice versa. If this type of chromophore is really few in amount in the tissues, so the absorption will be minimum, and this gives you how to increase or decrease the power of your device. I believe you don't depend on the parameters that's preset on the laser devices, whatever, with my all due respect to all the laser manufacturers, but I really don't believe that you have to be a button presser. Just select the application and press the button and do it. You never use the gingivectomy or whatever the application of soft tissue laser or whatever the type of laser, according to the precepts. Every patient you have to increase or decrease the power according to the nature of tissues, whatever it's thick by type, thin by type, vascularity, according to vascularity, according to thickness, according to the amount of keratin. You have to know the type of absorption channel of each type of laser. To summarize this, we have studied this graph. It's called absorption spectra or absorption curve. It describes which type of laser absorbed where. So the soft tissue lasers, to summarize, its chromophore is the blood component, the melanin, and the protein. So as long as the blood or the tissue I'm cutting in is really vascular, so the absorption is going to be high, so I don't need a lot of power, and vice versa. So, and also when I'm cutting in pigmented tissue or a dark pigmented tissue, you don't have to use a lot of power, you have to use a little power. So you increase or decrease the power according to the amount or the vascularity of these tissues and according to the pigments found in these tissues. Also, the main key of success in cutting in soft tissue using the diode laser or the soft tissue laser is controlling your hand speed. As long as the time of contact of your soft tissue laser tip increases with the tissue, you are transferring more and more temperature to the basal layers of these tissues, and all these is on the expense of the vascularity, the vascular area, which is gonna reheal this area after you cut. So when you transfer more heat to the deepest tissues, this will affect the healing period and will increase post-operative complications. So try to make your hand not too slow or too fast on the tissues in order to get really a nice cutting, a nice ablation without reaching this bad black color carbonization, which is sometimes favorable but in sometimes it's not. And if this carbonization increases, it may lead to necrosis. So too much heat will really kill the tissues. As for the hard lasers, or better call it all tissue lasers, because its chromophores for the RPMs are the water. It's called water laser, so it's working on water. It works on the water content of the tissues. Such when you point your erbium laser toward the tissues, the water content absorbs the beam of laser and it's popped out. It explodes. So all of our tissues in our body contains water, whatever it was hard tissue or soft tissue. It contains water. So the erbium can be used in all tissues, whatever it was, enamel, dentin, gum, skin. So we can use it in any tissue. The erbium lasers is a really useful tool, but its limitations in Egypt or out of Egypt, that it's really expensive. It has a real high price. It has a lot of uses, but if you invest in an erbium laser, the running back of money will get too slow. But if you invest in a diode laser and soft tissue laser, it's really useful tool, and the running back of money is really fast. So, but the main use of erbium laser, or the main referred cases for any doctor that has an erbium laser, is the veneer or crown removal. The erbium laser is really magical in debonding or removing of a veneer or a crown from the tooth. The dilemma of removing a veneer from a tooth in the conventional way using a handpiece is really catastrophic, and it takes a lot of time, and it may harm the tooth structure from beneath. But using the erbium lasers, we give out pulses that goes through the fitting surface of the restoration, and our main concern is to debond the veneer cement from the fitting surface of the veneer. And sometimes we can remove the resin cement from the tooth, as you can see in this picture. But as long as I have used erbium lasers since 5 years ago, and I'm using up to now, the best way to remove a veneer or to debond a veneer without harming the tooth is fixing the parameters in order to debond the cement from the fitting surface of the veneer. You can just destroy these veneers, or you can remove it intact if you need to just replace it or re-cement it if it's fixed in an improper angle, or a dark cement or whatever. If you need to remove it intact, I can remove it intact, and if you need to just destroy it, you can destroy it. You can remove a full mouth veneers in a time not more than 10 to 15 minutes without using of any anesthesia, without any pain. If you remove, in the times I have been referred to cases to remove a veneer and getting it out intact, it takes more time, but it's really useful. It removes it just like this, as you can see. Now the video is working good. In no time we can debond the veneer and getting it out in a really clean manner, as you can see. Okay, let's go for the diode lasers right now, and that's our main topic in this presentation or this live show. I want to clear out the use of diode laser or the soft tissue laser as a really useful tool in the aesthetic makeover. I'm presenting some cases in such a way that I have used only diode laser in these cases, and some cases I have used it as a tool in a company with another techniques. So let's go. First case, a gum recontouring case. This case came to me. It was referred that she doesn't like her smile. By the way, she's a blondie. As you can see, she's light skinned. She has blue eyes, but she has pigments in her gum. And her smile, she doesn't like it. She says that my teeth are short, my gum is dark. I have something that points out from here, from my lip. It's an overextended part of the labia frenum, and here I used only laser. If you can see this case in intraoral and lateral view. So let's analyze this case. It has short clinical crowns. It has an overextended part of the labia frenum that's disturbing her smile. She has a lot of pigments, physiological pigments in her gum. And by the way, for the pigments, you don't have to be dark skinned to get pigments in your gum. It's a physiological pigment according to the activity of the melanocytes, not according to the number. A lot of papers said that as long as there is a hyperactivity of the melanocytes, there will be pigments in the gum. It's really not related to the number. So we can see a light-skinned person and has pigments in his gum, and we can see a dark-skinned person, but he will be having a light gum or a pink gum. So it's related really more to the activity of the melanocytes. This patient is a smoker, so it's not really physiologic. It's acquired pigments. and the smoking really increased the activity of the melanocytes, leading to hyperpigmentation of the gum. So in analyzing the gum margin of these teeth, and after periodontal pocket measurement and bone sounding, we need to raise this margin to this level. We are limited to the pocket depth. You have to measure it right using an X-ray. If you don't know how to use it, you can get a specialized periodontist to do it for you, in order to not violate the biological width, not to remove too much. So the main concern here is to raise the margins to this level. And as we know, for the proportion of the gum margin, the canines should be on the same level, the centrals on the same level, the laterals will be beneath them about 1 millimeter. And as for the zenith point, which is the highest point of the gingival margin, it should go with the midline of the tooth, or you can say in some schools 0.5 millimeter distal to the midline of the tooth. So after this, immediately after I have done my laser treatment for this patient, I've started with the depigmentation. Then I have done the gum recontouring or the gingivectomy according to the pocket measurements and my limitations. And if you see the lateral view, that's the really good use of laser. It can be used in a really precise manner, in a conservative manner. We have used it to just shave this external part, the excess or the protruding part of the labial frenum, just shave it using the laser. And in each application of these, I have used a different parameter. I've not set it the laser device for a 1 power parameter for using all of these applications. I started with a low power for the depigmentation, then I have increased the power a little bit for the gingivectomy. And this is the case after 10 days of healing. Our main instruction for the patient is to just to avoid the thing that irritates the gum, includes smoking, spicy food, citrus food, hot drinks, and using a mouthwash, sedative mouthwash. So if the patient is committed to these instructions, he will be very good within from 1 to 2 weeks as a maximum. This patient, after just 10 days of being committed to the instructions, so we have shifted it from the above picture to the lower one in just single visit. Another case, this case needed a gum recontouring plus another treatment line, which is the veneers. This patient suffers from the gum smile. So the gum smile is not treated always using laser. It has limitations also. You have to know what's its cause, what is the main problem here in order to solve it. It may come from the gum, it may come from the lip, it may be a compound, a problem for gum, a lip, and maybe bone. Sometimes it needs an orthognathic surgery, and sometimes it needs only to lower the lip using a conservative manner like the Botox or such another surgical intervention like the lip repositioning. Sometimes we use a mixed technique using laser or a scalpel with Botox and just mixing line of treatment in order to reaching the final result. But in this case, the patient needs veneers, and after bone sounding and pocket measurement, we found that hair gum can be removed using the excess gum. We can use gingivectomy using laser. So analyzing, like the previous case, is the gum margin. According to the bone sounding and pocket measurement, we need to raise it to this level. As you can see, it's not uniform removal in such the left central, just we remove a little bit, not more than 0.5 millimeter. And in some cases we don't really do gingivectomy, just make a gum recontouring, just make shaving, just make some minor gingivoplasty. You have to be conservative as long as you can. So this immediately post-operative after the gingivectomy. As you can see, the pattern after cutting differs from the previous case. That's why this case has a more keratinized gingiva, a more thick biotype gingiva. So the heat transfer here was a little bit more than the previous case, but it's still acceptable. The whitish or the ablation or the whitish or the protein denaturation of this area is not bad, but try not to reach this black color of the carbonization in order not to do to reach the level of necrosis or this delay of healing and post-operative complications. So this immediately after recontouring of the gum, this immediately result. This after fixing her veneers. So we have done shifting this patient from this to that, mixing the technique of laser gingivectomy and DSD and veneers for this patient. Another case including veneer removal, gum recontouring, and final veneers. Do you believe that these are veneers? Really good, huh? It's a really bad case. This case referred to me for removing the veneers, and I have referred it again to my colleague in order to do her veneers because the case was not mine. I'm just doing the veneer debonding and the gingivectomy. The key of success of this case is you have to be patient in doing your temporary. As you can see, these are considered as veneers, but yeah, it's catastrophic. It's catastrophic restoratives. It's really bad with a real marginal leakage and recurrent caries and staining, very bad materials for veneers, and the patient is really not happy about it. Accumulates food, bad oral smell. As you can see, it's really catastrophic from the labial view. As after doing an x-rays and measuring the pocket depth, so this is the margins of the gum on the first case. Okay, this is the lateral view. As you can see, it's really bad. This after removing or debonding of the veneers. As you can see, there's something caries, sometimes calculus, subgingival calculus, and here, as you can see at the right central, this is not the root, this is the finish line of the old veneers. This after laser gingivectomy for the veneer, for the teeth, in order to harmonize the gingival margins, in order to reaching the optimum result for after doing the veneers, for the balance between the white aesthetics of the veneers and the pink aesthetics of the gum, to harmonize the gingival margins. That's the final gingival margin after recontouring using diode laser. So here I have mixed using of erbium laser for debonding of the veneer and the diode laser for recontouring. I always use the diode for soft tissue approach. I don't really prefer erbium laser because the diode is it's really more hemostatic. The field is less blood, with less blood, it's not bloody. The erbium gets out a little blood, little sip of blood, but it's painless. But here I've already given anesthesia, so I'm using diode. I just prefer diode for a lot of reasons, including the coagulative effect of it, and between you and me, it's really cost effective than the erbium, because the running cost of the diode is really way less than the using of erbium. So I just use the erbium in cases that's really just specific to erbium, like the veneer removal. This is the temporary, which is done according to the waxing up of the lap. The main key of success for these cases is to be patient with the patient. You have to leave the temporary restoration for proper time for proper healing. So this is the final temporary immediately after cutting. As you can see, the pink gum, no bleeding, the area is clear, and now and then, each, let's say 4 or 5 days, this patient came to me to remove the interdental acrylic from the temporary to give a chance for the interdental papillae in order to be intervened into between the teeth before taking the final impression of the veneers. Because the veneers finish line or the margins, it's an equigingival position at the margin of the gum. So I just leave the temporary for a proper time in order to gain the final healing of the margins of the gum before taking the final impression for veneers. As you can see, this immediately post-operative, and this is a patient after about, let's say, 5 or 6 visits of coming to me to remove the interdental acrylic from the temporary. The temporary acrylic veneer, I think it's way better than the previous veneers you have done. This is the final temporary after final healing. So I have sent it back to my colleague, the referred doctor. She has removed all the temporary. This is the final healing of the temporary. You can see the margins of the gum are homogeneous from the right to the left side. This is her veneers, and this is her veneers after fixing. As you can see, the margins is very good, healthy margins. The right veneer is a little bit tall, but is easy to be fixed. I'm here concerned more about the margins of the gum. This is her smile. You see the difference between her final smile and her first smile. Okay, one of my favorite cases in this case, because it's really life-changing case. This is one of my cases called Martha. Martha don't smile when this case referred to me. It's not referred to me. I have done it in the clinic of one of my colleagues. I've taken my soft tissue laser and done it right there. She told me she doesn't smile. She's her friend from the gym. We tried to make her smile, just a smile like this. We tried to tell some jokes. My friend tried to just tickle her in order to gain another smile. As you can see, a ghost of a smile. So giving out more funny jokes, more trying to make her laugh, we got this smile. And as you can see, after she smiles like this, just got tears in her eyes. So she started to say that I don't like my smile. So I just reassured her. I told her it can be fixed, don't worry. Analyze and make a treatment plan always before doing any intervention. So in saying intraoral, clinically, she has an old post-infused to metal bridge, fixed bridge from the canine to the canine, from right to left side. This is a gum line. After doing a comb beam and the routine of pocket depth measurement and bone sounding, we need to read the margins like this. As you can see, we don't remove uniformly from right to left. We just remove according to the pocket depth and the bone level, order not to violate the biological width. If you don't know how to do this, ask a specialized periodontist. It's easy. This is the lateral view of the bridge. This after pocket depth measurement to reinsure the pocket depth according to the x-ray, and we have done the template for her. In order to tell the lab we need the veneer dentistry design. So by combining the dentistry smile design, the cone beams, the pocket depth measurement, our x-rays, so we have reaching that we gonna remove a specific amount of gum, and as the previous case, I just started to calibrate, measure each tooth to detect my gingival margin placement, the gingivectomy of the right side. I'm now making sure that the right side will be same as the left side. This is after gingivectomy. As you can see, the pattern of gum is different in each case. In this case, it's really keratinized, really granular, as you can see. So I cannot use, that's why I've told you in the beginning of this presentation that you cannot use a single parameter for cutting all the tissues for all patients. It's really different from a patient to another. It's really different from, in the same patient, from one area to another. You cannot cut in a close to tongue or cheek, and the same in the palatal area or the J area or the labial. Each one has specific parameter for cutting. After the troughing, this is the final result of after gingivectomy immediately. So removing the old restoration, and as you can see, the left central tooth is root canal treated. It's dark in color. Always also the same as the previous case. I have done a temporary restoration, but here the problem is when I have left the clinic of my colleague, the doctor who's doing restorations in her clinic have been in a hurry that he removed the temporary in early time, earlier than the final healing. So he didn't wait for the final healing. The problem is, after fixing her final restoration, that is the final outcome. It's not really good, because as you can see, first of all, the margins of the left central and left lateral is not a proper not properly placed according to the right side. Also, as you can see, the margins of the gum is still open and the papillae is not really healed in a proper manner. The main problem here also is that the left central is fixed using a resin cement which is not opaque. So the color of the root canal treated tooth is really obvious. As you can see, behind the tooth, it's really black, because the material of the full coverage crowns here is made from an Emax. So the Emax is transparent, showing the color of the tooth behind it. So I use the erbium laser in order to remove this crown in a snap, as you can see. And I have placed the temporary again according to the waxing up of the lab and left it for a proper time. And after let's say from 20 to 30 days of temporary restoration and using a mouthwash, taking the final impression, sent it to the lab, we got this final result. That's the final result of the restorations. As you can see, very good healing, very good gingival margin, very good placement of the gum margin. The material of the full coverage crown is really good. This is the labial view. The one which was dark in color, the left central, I have used it a proper opaque resin cement to mask the color of the root canal treated tooth. The lateral view, even it looks good from the occlusal view. As you can see, the margins from the palate, this is the full coverage crowns from the canine to the canine. There's a smile of her. I've done a photo session for her because she was really happy. As you can see, she got a really good smile. So shifting her from here It's her smile right now. As you can see, it's really life changing. So from here to there, using not laser only, laser was just a tool for helping giving out a proper treatment plan. So my main goal for this presentation is the using of laser is not a magic tool only, but you have to know how to make a treatment plan. Just do the steps, and I believe that there's no such a dentist that can do every specialty in our dental field. There's an implantologist, there's a periodontist, there's a restorative dentist, there's an endodontist, and so on. So another use for the laser in aesthetic makeover is the depigmentation. As I have told you, that the pigments, it's either physiologic pigments increasing to the melanocyte activity rather than the number, or a pathologic, which is an acquired pigment like the heavy smokers, or if he's taking a drug for like iron supplement. It may be due to an amalgam tattoo, it may be due to metal oxide from a post-infused to metal crown, an old crown. Just you have to know the main cause of these pigments. If it's solitary or something, you don't know what's in it, just don't touch it until you ask a specialist in medicine, in oral medicine. It may be a melanoma, a angioma, just you have to know what is it before removing. But as for the physiologic pigmentation we see every day in a lot of patients, especially in Arab countries and in India, due to the dark skinned, which have more chance in more pigments or hyperpigmentation of the gum. We see it a lot in our Arab countries. As you can see, these pigments. The main concern of depigmentation is to abrade the top layer of the epithelium, which contains the melanin pigment. This process is done using a stone or a lancet, but it can be really bleedy. But using the laser, especially the diode one, the soft tissue laser, is really helpful. That this procedure takes not more than 10 to 12 minutes. We can use minimal anesthesia. I give anesthesia sometimes, or some doctors just don't do anesthesia, just topical anesthesia. I give a little bit of local anesthetics, just a minor injection, 2 drops between each teeth, to increase the procedure in order not to take a lot of time, and I don't want my patients to feel pain. This patient has as you can see, physiologic pigments extended from the anteriors to the posteriors in the upper and lower teeth. This is the immediate result of depigmentation of the upper left quadrant. This is the immediate result of the depigmentation of upper and lower. As you can see, this is immediately post-operative. No blood, not a sip of blood. It's really pink in color, and you can see even the stapling of the gum under the picture immediately post-operative. I did the healing after 3 weeks. He came to me and we have done bleaching for the teeth, also using diode laser. So I have shifted this patient from here to there just using diode laser only. Even now we can do lab depigmentation using the diode laser. Also, it's really a lot of cases of dark lips in our Arab countries, in India, and in all the countries that are dark skinned. This patient was referred to me from a dermatologist. She has done a fractional laser for her face at my colleague of the dermatologist, and she has referred her to me in order to do the lab depigmentation. As you can see, this is the immediate post-operative result of the depigmentation of the lip using diode laser. I also use it in a manner same as the gingival depigmentation, not so much different from it, but the instruction for the patient is also plus the previous instructions I've told you about avoiding smoking and spicy food and citrus food and hot food and alcohols, of course. Beside this, for the lip depigmentation, we say that the patient should avoid the sun, the heat from the sun, the heat from any external source of heat like the oven or a flame or a hair dryer, anything that gets out heat. He should be or she should be avoiding it until final healing. And this is the immediate result of the lip depigmentation. It is the healing after 1 month. It takes a lot of time to heal, more than the gingival depigmentation. For the gum depigmentation, the patient can be very good and final heal after from 1 to 2 weeks maximum. As for the lip, it may take up to 3 or 4 weeks to get this final result. So we shifted her from here to there just using the diode laser, the dental diode laser we have in our clinic. And we're still discovering up to now. In the end, I'm telling you that you have to think outside of the box. Don't be committed just to the main uses or the catalog uses or the brochure uses or the company uses of the laser. The laser is technology, and you have the creativity. That's what we get out, the innovations. The innovations is also related to your thinking and just giving out functions out of your devices and your science that accompany the science part and the knowledge part with the device you have any device, not laser only, but and never stop learning. And if you have speciality, I have used laser in a lot of specialties, but some specialties I've never used laser in it. It's not my specialty, like lasers and implant. I just I don't do implants. I have a specialist in implant. So read about it. It's really a good, useful tool. As I always say, just be a game changer, because the world here is already full of players, because the dentists here in Egypt and out of Egypt and a lot of countries right now, we have really increased in number. So you have to be unique in order for the patient to see something different at your practice. He can just go to you or go to your center and say, this doctor is really specialized in something. Thank you so much for giving me this opportunity to give my live show at your reputational page. This is my contacts on the Facebook, and this is my email. If anybody needs to ask something, just don't hesitate, or ask me on the comments or on the web page of Divas Laser. And thank you so much, and goodbye.